So Dr. Abdulla was born in Tanzania, and he received his MD from the University of British Columbia in Canada in 1975. And then he finished off his training in internal medicine. He had then proceeded to fellowship in cardiology in the States at the University of California, Los Angeles. I'd like to have your attention, please. This is an introduction. We have a guest. We should be courteous. And at the University of Southern California as well, USC, known as USC. He's practiced cardiology for over 30 years, provided healthcare in Canada and the USA, and Pakistan, and Kenya, and Tanzania, and Uganda. I think that makes sense, isn't it, Dr. Abdulla?
You got them all.
So he was recruited by the Untitled University to be the first head of the tertiary cardiology program. And he very successfully established a cardiology unit there, and then assisted the development of the AKU East Africa Cardiac Program in Kenya. That's all I'm going to say about him, and I'm sure you will discover a lot more during the course of the evening. So if you just hold on a moment, Dr. Abdulla, we're going to do a pre-test.
Sure.
Then I'll call you too. Dr. Abdulla and I talk briefly, and this is not a lecture. This is an interactive session. So you should have some questions to ask him, and he will try his best to answer them. What I would ask you to do is please do not make the question long. Please do not give a long speech about what happened in wherever, 5 minutes, saying this and this happened. Ask the question, and I will shorten the question, very short time, and also ask to give everyone a fair chance of asking a question. So if you have 6 questions, ask one of them, and if there's time, maybe to come back to you. Is that fair? All right.
First of all, I must say that I am very appreciative, and I thank the people who put this program together and gave me the opportunity to participate with the Qatar Jamaat and to discuss some of the important issues of health that affects our community. So thank you for giving me this opportunity. You know, I came to Kane, and first thing I realized is that there is a pre-test for everything. So Mukhi Sahib wanted to test if I'm a real Ismaili. So he made me say the Ginan. You know, I mean, there is a way of testing, but I mean, this was like a harsh. Mukhi Sahib, good thing. Good thing I knew one Ginan. The next thing that makes me comfortable in this Jamaat is that I come from a very small village in Tanzania. I grew up in a small village. We had a Jamaat Khana that was, I would say, almost identically this size. At our best population height, we had about 200 people in our village. And not everybody made it to Khane. And then there were periods when there were 100 people, 150. So when you went into Khane, it was very much like this. And when I came in here, I felt and remembered my time when I was growing up in Africa. So I felt at home, Mukhi Sahib, and it made me feel very good. So it's a nice feeling to be here. All right, so you have seen the video, and this video is just a small clip of a big program that I have developed for heart health prevention and stuff. And there are multiple such videos that I have done over the years, and they are all available on YouTube. So if you go Dr. Al-Nur Abdulla, cardiologist, Dr. Al-Nur Abdulla, cardiologist, I also have a YouTube handle, which is, at the rate, and then Dr. Al-Nur Abdulla, cardiologist, all one word. You will see all the videos pop out, and they are of different periods, different ways, women heart disease thing, and other sort of. Just did a recent one on dementia, which really went viral. I was quite surprised that people wanted to hear me talk about dementia, but it went well. So there is access to this material at your own leisure when you. Okay, Mukhi Sahib, I'm done. I've done my advertisement. So now I think it's best that you raise the issues and make me talk about things that you want to discuss, that you want to hear. And the floor is open with regards to all aspects of healthcare questioning that you want to do. Go ahead.
Doctor, my question. What is the sign of heart attack? Like, if we are, something is happened here, so I always say my husband, oh, heart attack. Heart attack, what? I mean, how we know that it is heart attack or what?
Very good question. Okay, so, males have a different way of presenting when they are getting a heart attack. And women manifest the symptoms differently. And this is why women are missed when they have heart disease and they have heart trouble, because they are considered as not actually having a heart attack by the emergency room doctor or the primary care physician. So the classical presentation of a heart attack is some kind of discomfort in the middle of your chest, but you can't pinpoint it exactly where it is. It just feels that it's somewhere in here. So there is discomfort is spread here. It sometimes radiates into your neck or into your arms, not necessarily both arms, one or the other. So the first is the location, which is across the chest, shoulders, or the neck, your jaw. Second is the type of pain. The type of pain that is felt is very difficult to describe. It's not like somebody is stabbing you with a knife. It's not like somebody is, squeezing the towel and, causing that discomfort. It's more like a heaviness or a pressure or a feeling of a weight over your chest or an aching kind of dull feeling. So sometimes it's mild and you tend to ignore it, and that can be a problem. So the discomfort is not knife-like. It's not sharp. If you're getting a sharp pain, then almost certainly it's not due to your heart. It's more of a dull kind of aching, heavy, pressure-like pain. So that's the second thing. The third thing about the heart attack symptoms is what is associated with the discomfort, what company it keeps, all right? So almost always there is sweating that occurs with it. So you tend to suddenly start to sweat. You don't realize, you haven't been rushing, you haven't been doing anything, it's kind of air conditioning is on, but you start to sweat. And that sweat is due to the autonomic nervous system being activated from the heart attack process. So sweating is a very common accompaniment of the other symptoms. And the other symptom, which is also a very common accompaniment with the discomfort, is a breathing difficulty. सांस लेने की तकलीफ होती है, डॉक्टर साहब मुझे घबराहट हो रहा है, सांस नहीं ले सकती हूँ, right? So that's the complaint that people have. And so there is this feeling you can't get enough air. And the other accompanying symptom, which is not very often but does occur, is a feeling of lightheadedness. You feel like you're going to faint. You feel like you want to sit down or lie down. You get a sensation that you're going to collapse. So there is what we call that ghabrat, and in English it is called a sense of impending doom. So something bad is going to happen to you. You get that feeling, something bad is going to happen to me. That feeling of impending doom. Then your body is telling you something. It's telling you something major is going on. The most important organ in your heart is getting damaged. You better do something. And people always tend to downplay the symptoms. They tend to ignore. They think, oh, it's not important because it's mild pain, or so it's little sweat. They want to attribute it to something else. Oh, it's gas, or it's reflux, or it's maybe my rib pain, or asthma or something. Don't do that. If you have any of these symptoms, some discomfort in this area, some feeling of dull pain, aching pain, heavy pain, some breathing difficulty at the same time, or a sweating that is out of proportion to what you are doing. It could be just sitting there and you start to sweat, or a feeling of lightheadedness. Do not ignore these symptoms. Now, this is the classical way that the heart attack patient present. But there are atypical ways. There are ways in which the heart attack is happening, but you don't know and you don't get all these other manifestations. The first thing that may happen, somebody may just collapse. They just faint, right? But they actually are having a heart attack because the blood pressure suddenly drops, the heart rate slows down, and there's no blood to the brain. Boom, you pass out, but you're still breathing and your heart is beating, but you don't realize that it is actually due to a heart attack. So that sudden collapse is also a worrisome sign. And in women, they get a lot more burning. They feel burning discomfort, and therefore they always think it's gas. Okay, I just ate this biryani, and I say, yes, you ate that biryani, that's why you're getting the heart attack. Just teasing. Okay, so women get a lot more burning. Women get a lot more dizziness and lightheaded feeling. And the discomfort for the women is almost always atypical. It's like a little pain here, or just the arm is aching a little bit. So women have to be even more vigilant about feeling and knowing that they may be getting a heart attack. So you asked a very long question, so I gave you a short answer.
Doctor, it's the same, just now you talked about the heart attack, pain here, pain here. What about the silent
Heart attack. Yeah, silent is silent. You don't know it. You don't feel anything, you have no idea, and you have had a heart attack. And then when you go to the doctor for some checkup or the other, then he does a ECG or he does an echocardiogram, he says, oh, you have had a heart attack. So there are a percentage of people who will get a heart attack but not know that they have actually had a heart attack. And if you have diabetes, it occurs more often. Diabetic people can have heart damage or heart attack without being aware of it. And this is why over a period of time, they go into heart failure. The heart is getting damaged, they are unaware of it, and therefore they are not getting the treatment, and lo and behold, they get to the stage where they are in heart failure. So diabetic patients have to be very careful to have checkups and things assessed on a regular basis, right? Professor Saab, should she be punished for asking 2 questions in a row?
We'll let her off.
We let her off? Okay, onward.
Can I just ask for a little clarification on that, Dr.
Sorry?
On the pain, when people present with pain, sometimes, as you said quite rightly, they dumb it down. But I think perhaps we can emphasize that if the pain persists and it carries on for 10 or 15 years, they must call EMS.
Yes.
Even if it makes nothing, they must call EMS.
Right. So, people get what we call angina. So they get this discomfort, but they get it when they're exerting or pushing themselves or rushing up the stairs. They get it. And then they stop or something, it goes away. They rest and breathing becomes fine and everything is okay. Like me. I mean, every time I'm going to these World Cup games and rushing through to the metro to the stadium, I'm already having angina. So that's a transient symptom. It comes, and when you rest or a few minutes, it goes away. So it's a warning. But if you are having a heart attack, then it's a definite, fixed process that is just going to carry on to its completion. And as Professor Saib said, the symptoms will persist. So, after about 10-15 minutes, you're sitting there relaxed and you're still sweating and the discomfort is still there and you're still feeling breathless. Do not ignore that. That's a very important thing, the persistence of the symptoms. Very good, thank you. Yes, boss.
What's the difference between cardiac arrest and heart attack?
Excellent question. It's in that same video. It's another part of that same video. Okay, I'll do that. So the young man is asking, what is the difference between a heart attack and a cardiac arrest? So I'm going to tell you the difference between three things: heart attack, heart failure, and cardiac arrest. All right? So first, heart attack. Heart attack is where there is actual damage to your heart muscle. The muscle actually dies because there is sudden occlusion of the artery that is supplying blood to that part of the heart. All right? The artery gets blocked. So the artery has a 30% blockage, cholesterol, maybe 40% blockage, and then all of a sudden, within a minute or so, a clot forms on that blockage. So this blockage, which was 30-40%, is now suddenly 100%. And suddenly the blood supply is cut off, and you get necrosis and damage to the heart muscle. And if you can get in soon, like the program, the first picture you saw of me doing the angioplasty procedure, you saw on the first slide, and that was my wife assisting me when we did our first angioplasty case at the Aga Khan University. So we get in there and try to open the clot and dissolve it or put a balloon and re-establish the blood supply to decrease the amount of damage, but we cannot completely take away the damage. So heart attack is death of heart muscle. Can be a small one, can be a large one. And it occurs because there is obstruction, sudden obstruction to the blood supply. All right? So that's a heart attack. It's a plumbing problem. It's plumbing. The plumbing is bad. Suddenly the pipe chokes off, right? And there's no water going. Okay, so heart attack is a plumbing problem. Heart failure is a pump problem. Pump. The heart is a pump. It pumps blood, right? So what happens when the heart is damaged over a period of time? Diabetes or heart attacks or high blood pressure, all those things weaken the heart over a period of time, over years. And the heart now is unable to pump the blood properly all around the body. It receives the blood back through the venous system. It tries to compress the muscle in the left ventricle to push the blood to the head and all over but it is unable to circulate the blood because it is now weaker. The pump has weakened, right? And the blood starts to back up in the lungs and you become short of breath. They say you have fluid in your lungs, you need a water pill, or you get swelling in your legs because you get fluid back up in your liver and your legs. So that is heart failure. Heart failure is not death. It's not sudden death, or it's not the heart stopping. It's the weakness of the heart where it is unable to circulate the blood that is necessary to continue the functions of the rest of the body. All right? So that's heart failure. And we know heart attack. So heart attack is a plumbing problem. Heart failure is a pump problem. So what about cardiac arrest, right? Cardiac arrest is a situation where the heart normally contracts rhythmically. And the way it knows to contract rhythmically is there is a pacemaker in your own heart which fires. And when the electrical signal goes, the muscles know how to contract. So the signal goes, the heart contracts, signal goes, heart contracts, like everybody is doing at the moment. All you who are sitting here, the signal is going and the next pulse carries on. You feel the pulse, right? Now, this electrical situation where you are actually having damage, then the wiring gets damaged as well. There is actually wiring in the heart through which these electrical impulses go, all right, from one chamber to the other. And that becomes damaged and becomes irritated. So now you suddenly start throwing extra beats when it shouldn't be there. You're sending off different electrical signals, not from your main proper pacemaker, but from the area of the damage. You irritated the wiring. So when that irritation gets totally out of control, so that the heart is chaotic, it's just getting signals all over, and it just is quivering. Therefore, it's not sending any blood. That is cardiac arrest, because that is seconds before you die. And if that continues, and you can't get an electrical shock or a defibrillator, you should all be having a automatic defibrillator in gatherings, and or if you can't, you're not in a hospital setting, or somebody doesn't know how to give you CPR properly, you're gone. So that's a cardiac arrest. Cardiac arrest is actually the process of dying. When you have a cardiac arrest, you are pretty well halfway to heaven and one leg here on earth, right? And people like me intervene at that time, and with Allah's grace, we have the ability and the knowledge of what to do and save many lives that way, even though they're having a cardiac arrest. But large number of people who have a cardiac arrest get it early during a heart attack process with the wiring getting, so they die even before the ambulance is called, or even before they can reach the hospital, like it showed. So cardiac arrest is an electrical malfunction of the heart. Heart attack is a plumbing blockage of the heart. And heart failure is the pump action weakness of the heart. Does that explain that?
Is the attack linked with the weight?
Sorry?
Is the attack linked with the weight?
Your body weight?
Weight of the body?
Obesity.
Obviously, yes, it is. So, there are lifestyle issues, smoking, high blood pressure, lack of activity, whatever. One of them is weight, overweight. Now you see many older people are big and have big weight, but they don't get heart attack, right? And then you see many people who are lean, but they just have a belly. You know that South Asian figure? All South Asian, we all have that figure from the side, right? That fat is a killer fat. That fat is metabolically active. It generates negative chemicals and hormones which lead to damage to the lining of your artery. So now the fat and the cholesterol and everything can stick, because the lining of the artery, which is nice and smooth, has been damaged. You understand? Due to those chemicals. So it depends what kind of fat you have. If your fat is accumulated around your belly, then you are going to be in trouble. That's called metabolic syndrome, all right? But if you have a different kind of a weight pattern, mainly around the buttocks, thighs, and shoulders and stuff, then that fat is not necessarily associated with heart attacks. So how will you remember this? If you look at someone, I'm not going to point it to anybody here. So if you look at someone and he or she looks like a pear, they are okay. But if he or she looks like an apple, they are in trouble. You got it? It's that body shape. All right? So, does that help? Yes.
I just want to ask, like, for example, if someone is facing this heart attack problem, but he is aware that I'm facing these sort of symptoms, maybe it's a heart attack. So whether there are any initial remedies he or she can follow till the time he will get some medical assistance?
Okay. So you're asking me a question. I'm going to ask you a question. Are you the lady that read the readout today? No, it was someone else, right? Oh, okay. All right. Okay. So the question is, what can you do yourself to help yourself if you are getting these symptoms and you recognize that it could be a heart attack? What should you do, right? Obviously, the first and the most important thing is to communicate or get in touch with someone or talk to someone or let someone know or call 911. Just make sure you're not alone in that setting. Somebody is aware where you are or what you're doing. So that communication, I think, is the number one thing. We all carry cell phones now, and we can dial 911 or different ways, or you can shout to your aunt who is in the next room or something, to come over. So try not to be alone. Second thing you should do is start coughing. Because as he said, you are going to get a cardiac arrest. And by coughing, the vagal stimulation is increased, and it is like getting a defibrillation. So you're doing your own defibrillation. All right? So you prevent that cardiac arrest phenomenon, particularly if you feel like you're going to pass out or so, the cough. And obviously don't remain standing or sitting. Try and get yourself down on the ground or flat, because what you don't want is to pass out. But if you are on the ground and flat, you're not going to pass out. If you're sitting or standing, you will pass out, and then it's going to be very difficult for you to get help or anyone to really help you. They come here and they all panic you, seeing you are fainted or whatever. So always say down. The next thing is, if you are able to get around and stuff, try and get some aspirin. Any type of aspirin. It doesn't have to be this type or that type. Any type of aspirin, any dose. You don't want to, at that time in the middle of a heart attack, try to read how many milligrams it is. Okay? ज़रूरत नहीं है वो बात. Aspirin दो ले लेना. Just take 2 aspirins and chew them. Why should you chew them rather than swallow them? Is it takes a long time for it to get into your stomach, get digested, gets absorbed, and goes into the bloodstream. That process is too long. If you chew the aspirin, it crumbles, and immediately from your mouth, inside of your mouth and the mucosa, it goes straight into your bloodstream, and therefore it can help. And why do we need to take the aspirin? Because heart attack is a plumbing problem, and there is a clot there, right? And you want to thin your blood so that clot dissolves or a bigger clot doesn't form. That's why we take the aspirin, because we know heart attack is blockage of the plumbing, right? And what does it block with? Clot. And so we want to prevent the clot from progressing or forming in the first place. So that's the other treatment that you can do for yourself. I think those are the main things that any one individual can do for themselves. But the key is not to be macho, not to feel, oh, kuch nahi hai, I'm okay. This is macho phenomenon. Don't do that, okay? Just be humble. You may be having a very bad situation. Ask for help. Just worry about it. It doesn't matter if later on you find out it wasn't a heart attack. Big deal, so what? But if it was and you poo-pooed it and you did not pay attention, it's a big disaster. All right? Okay. All right? And you want to make sure that you don't have something happen, somebody doesn't come into the house or steal that vase, right? So you make sure that all the windows and doors and everything are locked, and that you have a security system or alarm. So when you come back, your beautiful vase is still there and everything is okay. But if you took that vase and put it right there in the living room table, on the coffee table or something, you closed all the windows and stuff, but you left the back door open, is it going to work? You're going to more than likely lose that vase. So the risk factors are the same way. You can't just close the windows and a couple of the doors. You have to close all the bad things to protect your vase, the most important part of your body, which is your heart, right? So it is called comprehensive risk factor management. So all the risk factors should be equally managed. And so there are newer risk factors that we are now finding out that are equally important in leading to hardening of the arteries and heart attacks. And what are those? Social isolation, where you are not interacting and not socially active. You're not participating in groups and in communities. You are lonely at home, and you have no friends, or the family members are not looking in on you or whatever. And you get lonely and you get depressed. That is just as bad, if not more bad, in causing a heart attack than smoking. So social isolation, unhappiness, loneliness, depression are major risk factors that lead to it. During COVID time, so many people ended up dying of heart attack and they didn't know it, and they weren't aware, and they were just called COVID deaths and stuff. All right. So that's a newer thing we are finding. Right? The other thing we're finding is physical activity is very important. So you don't have to be a runner. You don't have to go to the gym and run in front of the wall on a treadmill. I mean, I don't do that. I mean, it's ridiculous, right? But you're going to incorporate activity into your lifestyle. And basically, you only need to do about 30 minutes of activity per day, 5 or 6 times a week. And you don't have to do all the 30 minutes at one time. You can do it in little bits and pieces, 10 minutes here, 10, 20 minutes here or there. And you incorporate the activity into your lifestyle, right? So you're going to the mall. What everybody tries to do is park closest to the elevator or the entry into the mall. Or you're going somewhere and you try to, park a little bit far. First of all, there's lots of space. Nobody's going to ding your car doors because it's not so tight. And now you're going to walk 100 yards or 200 yards into the mall. You want to go into that shop, but you're going to walk around the mall and come. So you have added maybe 3 minutes or 4 minutes to that activity that you were doing. But you have already added 300 meters or 400 meters to your daily activity. You're upstairs in your bedroom, you got ready, you shaved, you got your suit on, now you're going to go downstairs, or evening you're going down to the dining room, you're going to go eat. Yes, so you go down the stairs, but don't go to the dining table. Don't go into the kitchen. Go back up the stairs and then come back down. So you've done your stairs twice. It added maybe 1 minute, 2 minutes to your thing. Nothing got delayed, but you have done the activity and you have helped yourself, and you won't feel so guilty eating that peda that you were going for the table. All right. So those are important issues of management. But what you were implying is these medications that doctor give you, like statins and others, do they help? And I kind of sense your concern about medications. So there are 3 ways that we manage blockages of the heart. Cardiologists, we manage it 3 ways. One way is medical treatment, medical management, by giving medications. We prescribe statins. So we prescribe high blood pressure medication. We prescribe diabetic medication. So medication is one way. The other way we handle the blockages is angioplasty and stenting, to open out that blockage and then put a stent in there to keep it open. All right? So that was that picture there. I did that first procedure at AKU at that time. So that's angioplasty stenting, right? The big term now that all the doctors use is PCI, percutaneous coronary intervention. So you don't have to cut open the chest or anything. You do it through the artery, and you get that done. That's the second way. The third way we manage all these blockages is bypass surgery, where we open the chest or partially open the chest, and we bypass the blockages. So you have a blockage in the artery there, and you put another vein from here to here, and now even if this blocks off completely, the blood is going to bypass and continue into your heart muscle. So that's surgical approach. So the trick, what separates one cardiologist from the other, is knowing when and what medicines to use, in which patient, in what time, who should get an angioplasty or a stent, and when, or when is bypass surgery indicated. And there are different situations where I will see a patient in the emergency room and I'll rush him straight into the cath lab and immediately do an angioplasty and a stent. There are certain situations that the patient has even more blockages that I will manage with medications for 10, 15, 20 years, and they continue to do well, right? So that's the important part. This is where you should listen to your doctors. You should try to understand why they're making that decision. Ask them. Don't hesitate to ask, why am I not getting a stent? Why should I take the statin? So it's important to get the information. And Hazimam has said as well that you should get those checkups, and he has said in other formats that get a second opinion. And do not hesitate to get a second. I'll tell you why second opinion is so important. There is an expression in English which says, to a man with a hammer, everything looks like nails that need pounding. You got it? So to a cardiologist who does angioplasty and stenting, he's more likely to tell his patient, okay, I'll do the angioplasty and the stent. You with me? So you should get another opinion, right? So that you are properly checked out and the decision is made, particularly if it's not an emergency. But if it's an emergency, then usually all cardiologists will make the right decision. I mean, it's pretty clear cut, all right? So that cover your question to some degree, or did I miss a particular part?
Yeah, you covered it very well, but the problems are that getting a second opinion is
Difficult.
important.
Yeah.
Yeah.
Good, thank you. Okay. Yeah, so maybe we can do quick round of questions and quick answers.
Atrial fibrillation.
Yes, I got it. I know the question. I know the issue. Okay, atrial fibrillation is an electrical problem. It's a different kind of electrical problem on the upper chambers of your heart, not the lower chambers. And everything is chaotic, and the heart is beating in a chaotic fashion, and the blood is not getting efficiently pumped out of your heart. So the blood backs up in the upper chambers. Because it backs up in the upper chambers, it can clot. So that clot can then get into the lower chamber and be pumped out into the circulation. And if that clot ends up in your brain, you get a stroke. So every patient with atrial fibrillation should be considered whether he should be on proper, strong blood thinners. So that's the most important thing about atrial fibrillation, is to know whether you should take blood thinners or not. And the second thing is to control the rate from being too fast, and you can then go for ablation if you want to try and reverse the atrial fibrillation. Got it? Ablation medications to control the rate, blood thinners. That's atrial fibrillation.
Sir, you said that you have to remind me for genetic.
Yeah, I'll get to that. Let's get some questions through.
So we have a small boy who is willing to ask you a question.
Zarur.
Still.
Does heart attacks still happen to young ages?
Yes. He's asking whether heart attacks can occur to young kids. Yes, yes. There is a problem genetically of you developing high cholesterol from young age, from inside. It's a genetic mutation which is called familial hyperlipidemia. So you could have one gene that has that bad mutation, and that's a heterozygote. The other gene is okay. So your cholesterol level goes up faster than everybody else with the same food that they eat, and you end up getting heart attacks in your 30s and in your 40s. Now, some people are born with two copies of the bad gene. They get it from their father and they get it from their mother as well. So now you got a homozygous familial hyperlipidemia. Those people are born that way, and their cholesterol level starts to go up at the age of 1, 2, 3, 4. And many of them will get heart attacks before the age of 10. And some will survive to 14 or 15. And until very recently, we were not able to control these patients, and they were ending up having heart attacks in teenage years or younger. Now, with the strong cholesterol therapies that we have, combination of statin, PCSK9 inhibitor, ezetimibe, we now can get these cholesterol down significantly, and these kids are now living into their 30s and 40s without having had a heart attack. So yes, young kids can, and this condition is not that uncommon. You know, actually more people have it than they realize. So they have the heterozygote, one bad gene. So you should know that. And it's important when you're family planning and all this stuff, and knowing that your husband, these are easy things to get checked out. And you have to be careful what may happen to your offspring.
Some heart attacks are in sleeping time.
Sleeping time?
Like somebody is sleeping and they don't wake up.
Yeah. Well, the commonest time that people get heart attack or strokes is between 6 a.m. and 10 o'clock in the morning. That's the most dangerous period. And the reason for that is the circadian rhythm of your heart, of your body, and the hormones, that, you know, you are supposed to be at your calmest, at your steadiest pace between 4 and 5. Physiologically, I'm talking about. And that's the time where all the bad hormones are still asleep. And your heart rate is not unduly going up. And your blood pressure is not unduly going up. So after 5 o'clock, the body has a clock inside. Whether you are sleeping till 10 in the morning, it doesn't care. Around 5:30, it starts its circadian rhythm. Starts producing aldosterone, adrenaline, all the bad hormones. So the heart rate starts to go up, the blood pressure starts to go up. So it is a period of stress to your heart. So if you already have blockages, that's the time you're going to get a stroke or a heart attack. So that's the circadian rhythm portion. And you can't say, oh, I'm just going to sleep until 12 o'clock or 1 o'clock every day and I'll not get it. No, it will still happen. The rhythm inside is set.
Sir, मेरा एक quick question है. आपने हम लोगों को इतना डरा दिया है.
Aha.
Okay, बहुत डर गए हैं. So now, how to check?
How
like
to-
as a normal person, how to go to doctor कि मेरा heart check कर रहे हैं.
Yeah. वो एक दूसरे सेमिनार का टॉपिक है. आपको मुझे दोबारा इनविटेशन भेजना पड़ेगा. मैं दोबारा आऊँगा और आपको ये वो चीज़ सही तरह समझा दूँगा.
So I think, Amit, you have your hand up.
Yeah, just a quick one. With all these technical, technological advancements, you have a wristwatch which is measuring your blood pressure, your ECG, your O2 levels and everything. When you're saying that you could misunderstood the symptoms of heart attack with something else, how can we use this technology to say that is it a heart attack or not?
These wearables, as we call them, are becoming extremely good and extremely beneficial. They are giving the control to the patient to figure out what's happening to them. And at the moment, the ECG part of all these wearables, whether it's in a watch or a cardio device or whichever way, is perfected. So that ECG can show you if that electrical problem is already started and there are extra beats and things happening. Then you know, better get worried. Or if you get atrial fibrillation, boom, it will tell you. You got atrial fibrillation. It was normal rhythm 5 minutes ago, but now you are in atrial fibrillation. So those things are excellent. The rhythm assessment on the wearables is perfected and is excellent and very useful. The blood pressure measurement part still needs a little bit of quality control assignment. The O2 saturation, the oxygen saturation is very well perfected and is extremely helpful, but only for people who have lung disease or have already heart failure, where they are hovering around 94% saturation and they drop to 85. I mean, they're in deep trouble. Those are the people who need to monitor. You and me and regular is not necessary.
So, who hasn't asked a question?
Does EVM cause heart failure?
Sorry,
Does EVM cause heart failure?
I missed that.
AVM, arteriovenous malformation.
Oh, yes, very good. Oh, you had a great question. AVM is arteriovenous malformation. So what happens in your body, you have arteries that supply blood to all the organs. And then you have the veins that bring blood back. But the arteries do not connect directly to the veins. They go through a network of tiny blood vessels called capillaries. So the normal system into any organ is the artery, then the arteriole, and the arteriole goes into the capillaries. The capillaries then pick up the blood in the venules, and the veins then pick up the blood and bring it to your heart. When you have an AV malformation, arteriovenous malformation, there is direct connections between the arteriole or artery and the veins. So the organ is not getting perfusion. There is no capillary flow. There is bypass of the blood from the arteries to the veins and back to the heart. The organ doesn't get full circulation. So it can be a bad problem. Those are almost always genetic, and one of the problems is that you can get hemorrhage, and that's always a risk that we worry about with AV malformation.
Okay, so one last question.
She just answered my question.
Percentage is what you have defined, 40, 28%, 40%. Are these common in men and women, or should be different ratios in men and women?
You're talking about the blockage or the death rate?
So the cardio issues identified in men and women ratios are similar, equal, or different?
Very good question. Very good question. As you look at men and women, and you look at the risk of heart disease or heart attack or any type of heart disease, men start to get it more, and women don't get it as much until about the time of menopause, and in their 50s or 60s. Then men still continue to get increase with age, but women get a certain rapid rise. So by the time they are into their 60s or 70s, more women are having heart trouble than men. So there is a changeover, and that's related to the period of menopause. And many things happen during menopause, hormonally and otherwise, that we have now learned that we have to address if we are to prevent this epidemic of heart disease happening in women after menopause. You see?
So I think that's really, really good.